Right. Thank you. We'll come to order. Welcome, everybody. Thank you for being here. It is 1 o'clock. We have a quorum. We'll get started. Uh, First, let's start with agenda item number one, review and revise the agenda. Do we have any revisions to today's agenda? No? Perfect. All right, moving on to agenda item number two, our minutes from our February 26, 2026 meeting. If you want to take a look at those, do we have any corrections to those minutes? No? All right, the minutes will be approved. Moving on to agenda item number three, immunization services.
Hi. Sorry, I was sick last week, so I still have like a lingering cough. So if I start coughing, I have my water. I'm
Shelley,
chair and member of the board. Do you want me to go
do
there?
no, do you want the podium or anything?
fine.
No, you're okay where you are? Okay.
Everybody else is good. So I'm Shelley Mogg, a public health nurse, supervisor here at Lewis Clark Public Health, and we annually try to do a little like update on immunizations. Wasn't sure really what you wanted to hear, so I just kind of put a bunch of stuff together. As you can see on the slides, it's kind of our numbers of immunizations that we've given over the last 3 calendar years. So it gives you an idea. It does include TB skin tests, which really aren't immunizations, I guess, but it just keeps us busy, the TB skin test. So I did include that. So pretty average numbers for the year. Our focus populations, we don't have enough staff to do the whole community. That's not our goal. Our goal is to really focus on those populations that maybe can't get their vaccines elsewhere. We can see anybody who comes in for vaccines, but our real focus is for those who really have barriers. So those might be individuals without a medical home, individuals without insurance, individuals whose insurance doesn't cover vaccines or the vaccines costs go to a deductible. Those who are planning international travel. There's a couple pharmacies that do international travel vaccines, but other than that, we are the only ones in town that do the unique travel vaccines. Those with conditions needing specialty vaccines. So those with no spleen, let's say diabetes, little ones for the RSV season. And then we do help Pureview Health Center. They do some basic vaccines, tetanus, flu, COVID, pneumonia, but then they'll just walk their patients over for us to give all those other ones if their patients need that. And then those facing the other barriers to care, let's say if they don't have transportation, we go out in the community and do some vaccine clinics to come and reach them where they are. We really just encourage people to get vaccinated where they can. Like I said, they don't have to come into us. We just want them to be able to access services.
I have a question about the international travel.
Uh-huh.
Do you have to call ahead because there's some specialty, vaccine
Yeah.
so that you guys have it?
Mm-hmm. Most of them that we give routinely, typhoid is a very common one. Typhoid is very common because it can be spread through water and food or people preparing your food in other countries, and it's endemic in a lot of countries.
Mm-hmm.
And then like Japanese and encephalitis, we keep a couple doses on hand because we can it's a 2-dose series. If a couple comes in and gets one, we can order it so fast. They're so expensive that we don't like to keep them on hand.
Mm-hmm.
Once there's a chikungunya, it's called. It's a kind of it's a new vaccine, kind of emerging epidemics. And so that one we do have to order. And usually they'll come in for their appointment, kind of get the other ones. They'll say they'll agree that they want it, and then they're going to pay for it because it's expensive. And then we'll go ahead and order it. And it comes in the next day. So It's pretty quick.
Where does it come from?
We order it through Henry Schein because that's the one that is easier. So it's the Bavarian Nordic, I think, is the one that makes that one. So,
and where are they? Like,
yeah, yep, in the United States.
Are they?
Oh yeah, usually back east is where our distribution for those vaccines are.
They get there that fast?
Yeah,
That's amazing.
you don't know how. I don't know how. We get it like within 24 hours.
Yeah, because
Yeah.
even if you overnight something, it takes
You don't
2
get
days.
it. Not in Montana.
Mm-mm.
No, it takes 2 weeks to order from Amazon, right? But yeah, it's fast. So it really works out well because those are just so expensive.
Mhm.
Most vaccine distributors we can return if they expire
Oh,
and we get a
wow.
full refund, but
Oh, wow.
those specialty ones you can't.
Uh-huh.
So I just keep a little bit on hand because we
Mhm.
don't want them to expire.
Okay, good to
Yeah.
know.
Yeah.
Our church does missions,
Yeah.
overseas missions, so
Yeah.
it's good information.
Yeah, and it depends on where you're going. Typically, Hep A, which is a pretty common United States vaccine, and then typhoid are the two most common that we give.
Mhm,
But
mhm.
there's some
Depends on the country.
Yep.
Yeah.
And the sooner you know you're traveling, call.
Yeah.
Because then they can help you time your
Mhm.
vaccines and make sure that we're prepared.
There's a couple, yeah. So we do a subscription to it's called Shoreland Travax. They keep up to date, real time, what's going on in countries. And so I get emails all day like, oh, now there's this in this country. Now and it's even safety things that they have on their site, not just vaccines, it's other epidemics, safety concerns, civil disruption, unrest. And so we do that. And that's why we do charge for that appointment because we do that subscription. We do a lot of research. We want to give them all the information that they need, not just about vaccines, just safe traveling in general.
Yeah.
So, and we also do group. So if somebody calls us like in that instance and says, we have 8 of us going, we will come to the group and do our thing as a group instead of 8 people and have to make appointments. It's better for everybody, really. So we do offer that too.
Okay.
Yeah.
Thanks.
Is that, sorry, you mentioned that you charge for that appointment. So is that a like flat, is that, all appointments cost the same or does it depend on sort of insurance or coverage?
Insurance doesn't cover for the consult.
Okay.
Visit. The vaccines are different. It just depends on the
Yeah.
insurance on the vaccines. Travel vaccines aren't always covered by insurance.
Okay.
So we do pretty common practice. This pharmacies and other health departments, we're right in the range with them. We charge $80. If there's an additional traveler, we add on a little bit more. If there's more than one country that we have to do more research, we add on a little bit, like $10 or $15. I can't remember off the top of my head. But we looked at the other health departments and the pharmacies and kind of got right in range with them. But that helps cover the nurse time and the subscription that we have to pay for to be able to keep up to date on all those specialty vaccines and the time it takes to order specialty vaccines and all that. So yeah.
Do you do malaria scripts?
We don't do malaria scripts. So what we do is if they need malaria, we will give them information, help coordinate how they can do that, like give them what they need and when, and then they'll have to get it from their provider.
So you'll say what they should ask the provider for.
Yeah.
That's very nice.
And the diarrhea, we say really encourage ask your provider for a anti-diarrhea medicine too, just in case.
Yeah.
Yeah. So yeah. Awesome. We offer all routine vaccines, childhood and adolescents, single antigen and combinations. So as you guys know, in childhood is the age where most of the vaccines are needed. And we just offer everything because everybody that comes in either wants one or they want all, or it doesn't matter to us. We just want to have it available for them. Adult vaccines, again, single antigen and combination. So what that means is if you're going to travel and you need Hep A and B, we could give that if there's a combo one that you can get it together and get one shot is what it is. It's the same vaccine, but they just are able to mix it. So, specialty vaccines, we just kind of talked about that. So specialty vaccines can be those travel vaccines. We have rabies pre-exposure and those specialty vaccines that maybe adults need because they have special comorbidities that they normally wouldn't get. We carry those too. We do TB skin test and TB blood tests. And these screen for latent TB infection. And then we do titers. So if somebody came in and said, oh, I'm really worried about the measles outbreak. I swear I had my vaccines as a kid. If they wanted us to just draw their blood and see if they're immune, we'll do that. They don't have to get the vaccine if they don't want to. We can draw their blood and they can test for immunity. So our off-site outreach events, our goal again is to meet them through collaboration with partners throughout our community. So we go with other programs within public health, the prevention team, WIC, whatever. And so if they have events, we might go with them. We join Peerview Health Center on some of their outreach events. MQA, Caravan, we join Caravan a lot. Caravan helps cover costs for people. Love Caravan, just saying. And they help cover costs for people who maybe need a vaccine that's not covered under insurance and we don't have it with our free program, they'll help cover the cost. St. Peter's, we'll collaborate with them a lot. Helena College, we go there quite often. And Head Start, which are for littles. And then whatever comes up, we try to jump in there and do it. So we do follow ACIP or CDC recommendations. We try. You know, it's kind of, it is our responsibility. So we have to, as nurses, especially me, has to keep up on any recent recommendations because we don't want to continue to do vaccines if something changes, the recommendations changes. So a good example, sometimes the vaccine might go to 3 doses and now they've shown immunity after 2 and they decrease 1 dose needed. So we just change our orders to fit it. We are nurses, so we can't just give vaccines. We have to have a medical provider that actually signs our standing orders that says this person at this age with these comorbidities can get this vaccine. He signs it and we have to follow those orders. So we just don't willy-nilly give vaccines to anybody who walks in. And those orders are based off of the ACIP recommendations. Every Lewis and Clark public health nurse understands each vaccine to whom it's recommended for, side effects, contraindications, precautions. We follow the standing orders. Recent recommendations it's called based on shared clinical decision making. And this really has made no decision. We never have somebody come into our room and say, these are the vaccines you're going to get. We'll be right back. Goodbye. We sit and we really we have them fill out a screening form and we look at all of their other illnesses that they have, allergies, why they need the vaccines. We talk to them. It's an informed decision. And so so shared clinical decision making, that's kind of what that is between you and the person who's getting the vaccines. And they make an informed decision on which ones they want to get. We always try to find historical immunization records to prevent extra doses. Extra doses don't hurt you. But why give it? If, some people come and say, I need a tetanus or on the schedule for a tetanus, we pull up the state immunization site and they had a tetanus 2 years ago, but they didn't know. We're like, you don't need a tetanus. You already have it. And they're, woo, thrilled. They're very happy. So we really try to avoid, if we have to fill out a release of information for like another state, we'll do that. But we really try to avoid giving extra vaccines if they don't need it. We give them federal law requires everybody get a vaccine information sheet, and that is an information sheet on that individual vaccine. So if they get 3 vaccines, they get an information sheet on each of those vaccines, and it talks about what the vaccine is for, side effects, how to, like, if they did have an adverse event, let's say, how to report that. I mean, it just talks about everything, and that's for their information. So they know everything about that vaccine. Not everything, I guess. The packet insert has a lot more information, but all the stuff they need to know. And then we believe, again, it's their choice. Some people, they are getting their child vaccinated and they want one and they want a specific brand name because that is what they feel is good for their child, good for them. And usually we'll have that brand. There's some we don't, but good for them. They're here, they're getting a vaccine, and that's what makes them.
So you do carry most of the brands that your parents asked
Yes.
for?
We don't carry Active though.
Okay.
Yeah, Active is hard. I don't know if anybody in town carries that, but Daptocil we do, and that's a common one. That it's a brand of a DTaP for little ones, and that's the brand that parents usually want, and we do have that, but we don't have Active. We have EVAC, so we still have Active, but not that one. Do you get Active too?
I get parents asking about specific brands.
Yeah.
Based on specific guidelines they have read.
And we try to help find it for them. I usually call the state and ask if they know who carries it to kind of help them be able to find it if they do. But there's a couple of them that are hard to find.
Do you have a sense of like why people are requesting? I've never requested a specific brand of vaccine. Like,
Yeah,
content.
Yeah, go ahead.
It's a specific set of guidelines that one physician has posted online. And it's in a pretty popular book that recommends specific brands primarily based on aluminum content.
okay, so it's like the formula. It's not like efficacy, but the formulation.
Correct.
Okay.
Mm-hmm. Yeah. Yep. That's it. I mean, quick and simple. Any questions? Good questions so far.
I have a question, but I don't know if you can answer it. Do people who go out in the field get vaccinations? I used to be a county sanitarian, hundreds of years ago, and we were through the health department. We received like hepatitis shots, and you just said it.
Yeah. tetanus.
Yeah, tetanus, there you go.
Mhm.
So we have an employee immunization for our
Okay.
employees,
Mhm.
and we go off CDC recommendations.
Mhm.
Interestingly enough, Hep A is not recommended for sanitarians. And so I was like, yes, 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 let's put it on there. But we haven't yet because it hasn't changed. It's not recommended right now. But yes, all of our employees that start have options to be vaccinated against tetanus and whatever they need for their specific role.
No, nothing's required.
Nothing's required, no. They
We,
have the option of, yeah.
Right.
And we educate them and tell them why they might need it. And like I said, hepatitis B, somebody at the front desk doesn't need hepatitis B vaccine,
Right.
right? A nurse needs hepatitis B vaccine. So it's specific based on their role.
and their risk.
Uh-huh.
Yeah. Risk of exposure is where the recommendation comes from.
Gotcha.
Yeah.
Where someone needs a vaccine that falls out of a pretty standardized protocol, like your patients without a spleen that need vaccination, do they need a list from their physician, or
Nope.
how do you do that?
Nope. We have our standing orders are specific and they cover like an example is Hib. Hib is a childhood vaccine, but somebody without a spleen or is going to have a splenectomy needs. It'll say Hib is recommended. We have an adult order and a child order. So that adult, if they meet these criteria, and spleen would be splenia would be one of them. And so our nurses would look and know that they could give it. The problem with that, and that's where Caravan helps us out a lot, is insurance will cover Hib for a adult. I mean, it's hard. It's hard to get it covered. We try.
Like a post-transplant or.
Yeah. And so sometimes we will call Caravan and be like, oh my gosh, we have this patient who really, really needs this and it's expensive and they help cover the cost. Yeah, those are really hard ones because they don't come. We also have, I didn't talk about this, but we have BFC and BFA vaccine. So we have like 2 fridges. One is we call private. We buy those with our budget and we bill insurance and we get reimbursed. The same vaccines are in this fridge, but these are the ones we get from the state that are free. And so we have to screen every person. If they don't have insurance, we can grab out of here and give them the vaccine and it doesn't cost them. But the adult ones are limited on the free ones. Therefore, they're the typical adult ones. They're not those specialty Hib ones. So we are kind of limited on that too, because that would be easy if we could just carry all of them free.
Yeah.
I think they should all be free myself, but
Sorry. Go ahead. In the couple of cases where ACIP and CDC guidelines are different than major medical society guidelines, are you including counseling about like what the American Academy of Pediatrics is saying at this point?
that's a really hard question. So the problem we're having right now is our free vaccines can only be given under ACIP recommendations. So we've talked about changing our orders to fit FDA or Academy of Pediatrics or family physicians, but we also don't want to be, biased. Like somebody comes without insurance, oh, you can't get that because that's not ACIP recommended, but it is here. Fortunately, so it's tough. That's a tough one. Right now, we are following ACIP, but there hasn't been enough changes in ACIP to really change
It's
anything
still all
yet.
shared decision making.
Yes.
Yeah.
So there hasn't been anything there yet that has made us have to make a decision. So we do still have ACIP orders. COVID in the fall, we did start off of FDA because ACIP was taking so long to make a decision. But that was the risk we also have is insurances go off ACIP. And so if the insurance decide they're not going to cover it because ACIP hasn't voted on it, we also risk of not getting paid and we can't afford these vaccines without getting paid back. So it's
Turmoil.
yeah, we talk about it a lot. We think about it a lot. Right now we're okay. But we do follow it a lot, really close. Good questions. Any other questions?
Nice job.
Okay.
Thank you.
Thank you.
Yeah, thank you.
Thank you.
Thanks, Shelley. And you made it through without coughing.
I know, that's good. Just getting back.
You weren't getting that.
All right, agenda item number 4, air quality.
Yeah, Jake today.
Here or?
Wherever you'd like.
Okay, well, I guess I'll stand here. All right.
Starting with your presentation or your letter? I put the presentation.
Well, okay, you all have a letter regarding our air quality program, which generally I'll give a presentation every year, because we do have some new board members that are unfamiliar why we have an air quality program and what the purpose of it is. But if you've read your report in there, it basically summarizes from July of 25 through present day today or last week, which has been a pretty non-eventful year. And if we can say it's non-eventful, that's a good thing. Because if it's not eventful in the summer, it means we have minimal wildfires, minimal wildfire smoke, which we did have wildfire smoke, but it primarily came from Washington, Oregon, California, and Canada, and Idaho. So we were doing pretty good, but unfortunately the prevailing winds come out of the west, push it to us. So we had to deal with some of that, but those impacts were minimal. Our air quality monitoring season, which pertains to our air quality or Lewis and Clark air quality ordinance in regards to our air pollution control district, basically runs from the months of October 1st through March 1st, and our winter airtime burning season. And that is in effect basically because of we're in a valley here in Helena, and Sandy, if you hit the next slide here. Our air pollution control district is shown here, basically from the North Hills, South Hills, right along the Spokane Hills, up and right on the edge of the front there on the west side towards Austin, which this tends to collect air. We get inversions in this area, which trap in a lot of the pollutants from vehicle exhaust, wood stoves, any other, burning devices be out there. But so, and the non-eventful part of this winter, October through March 1st, was that we had a very different winter. It wasn't real cold for most of the winter, and we had a lot of wind. And much as I hate wind, it does scour out the valley and keeps our air, our pollutants from building up. So, as you read through there, we dealt with some complaints throughout the year, or especially this winter, of open burning. People burning potentially prohibited materials like garbage, plastics. Generally, we'll get those complaints. We go investigate. Sometimes it's maybe just an upset neighbor that says, you know what, I'm tired of my neighbor burning stuff out in his backyard. I think they're burning garbage. Sometimes they are, sometimes they aren't, but until we find out, we don't know. And some of it, people with wood stoves that, burn during different times of the day, different times of night that cause issues. But we didn't have a lot of that this year. But so primarily what I'm focused on here with this PowerPoint is inside our air pollution control district. A little history of why we have this, just so some of you know. Back in 1967, the State Board of Health and Environmental Sciences adopted air quality standards for different pollutants. One of them being PM10, PM 2.5, carbon monoxide, different things like that. 1968, the Clean Air Act of Montana was adopted and requiring new sources of air pollution to obtain air permits. As you move through, basically in 76, East Helena lead smelter began installing an acid plant, which eliminated about 85 to 95% of sulfur dioxide emissions in the community. They had became a non-attainment source, which since has been eliminated due to the elimination of the East Helena plant. 1979, Montana Ambient Air Quality Study leads to enforceable standards, and standards apply to carbon monoxide, fluorides, lead, hydrogen sulfide, nitrogen dioxide, photochemical oxygens, and particulate matter, primarily what we deal with here at the county level. DEQ will deal with, in the valley, carbon monoxide and O2, different things. But in 1980, the Montana State Board of Health and Environmental Sciences adopted new enforceable air quality standards. And at that time, in the Helena Valley, 2 air quality samplers were located. One of them being out at Rossiter School, which today exists and is one that we use, and also one was at Lincoln School, which when I first started, we were doing both. And DEQ determined that the results and the data coming from Lincoln and Ross are about the same. So they eliminated, to save money, that Lincoln school monitor. Yes.
Where do the fluorides come from?
It's a good question. I can't answer that. Vehicle exhaust, different factories, different chemicals being burnt, but I don't know that we really have any of that here in the valley.
Yeah, I've never heard of it.
Yeah, we don't have a lot of that.
Not airborne anyway.
Yeah, you'll see some stuff with vehicle exhaust, diesel exhaust, but I'm really not sure around here if we see it. So a little history at the local level. In '85, petitions were signed to support the creation of a local air quality program. And in 1985, the commission adopted the first Lewis and Clark County Clean Air Ordinance. Okay, and in 2011, they made their fifth revision of the ordinance. This is still the ordinance we're operating at this time. We have reviewed this. We have to review it every so often, but pretty much things are still the same. So we also deal with what's called National Ambient Air Quality Standards, EPA NAAQS, which are set forth by the Environmental Protection Agency. We deal again with PM 2.5 here. Our main focus when we look at, well, we used to deal with PM 10. PM 10 now is pretty much, regular monitored by DEQ. We're focused on the smaller particles, 2.5, which would be 2.5 micrograms per meter cubed, which is the size of that particle. So, but our main focus is this right here. 35 micrograms per meter cubed, which is the set. If you cannot exceed that so many times throughout the year. If you do, you become what's called non-attainment. Missoula, it was non-attainment. Butte, non-attainment. Up in Libby, they were non-attainment. They all deal with similar problems we have as far as valley inversions, so on and so forth. They had, like Missoula had the wood mills, which were a large source of PM 2.5 pollution. Okay, that since has improved, but so that is what we want to try and stay under. And we have not really had to deal with that very much since about 2017, where we had a lot of inversions that lasted for weeks on end, 1 to 2 to 3 weeks. And that all that pollution from wood stoves, from cars, buses, trucks, trains built up and just wouldn't blow out. It just sat there. So next slide, please. So wood smoke is identified as the main source of PM 2.5 in the county or in our valley, basically. It contains carbon monoxide, organic gases, nitrogen oxides. So that's generally what we're looking at when we're in the wintertime, at least. So next slide. Health effects of PM 2.5, very small, going right into your lungs, absorbed into the bloodstream. So it's very hard to keep it out of your body. And it stays there for long periods of time. So people with asthma, different breathing issues, it's really going to affect them. And this is the thing we don't like to see is a big inversion where you start seeing the big smoggy looking valley. We had a few valley inversions this winter early in the morning. Generally, they would break up by noon. And, they figure it takes about an 8-mile-per-hour wind to flush out the valley because it's shaped like a bowl. And if you have winds less than that, basically all that does is it sloshes back and forth from the west side back to the east side, and you get those particulates, so they just don't go anywhere. And you have the warm air come in, puts a lid on top of that cold air. So we usually see these after a cold front or a cold, where it's maybe 10, 15 below. That cold air gets trapped and it just builds up. So it could be up, you up to Great Divide skiing and it's 35 degrees. Well, it's still 10 down in the valley. So again, we are susceptible to those inversions. And the big thing is what we put in is what we're breathing in. So, or what we put out, what we're breathing in. This is a picture of the Rossiter School monitor station. It's basically like a little shed. You just go in one side. They have these different air intake inlets that suck in the air. They pull it through different, what they call an impact filter, which basically removes the little particles from the air, puts it on a filter tape, and then we go out every once a week and read those. And then if you've ever been to like Today's Air on DEQ site, gives you an hourly update of what those particulate levels are. So you want to go out for a run, you want to go jogging, you can see what the last hour was. Okay. So we change the filters on those. That's part of our contract with DEQ, part of what we do. We have a couple different types, one that runs once a week and then the ones that run 24 hours a day. There's two of those out there. So based on that data, as far as our air quality program, as part of our enforcement, we have 3 air quality designations: good, watch, and poor. And pretty much like it shows, it's very simple. And these were designed years ago when the regulations came out as a way to help people who have a solid fuel burning device, like a fireplace or a wood stove, know when they should and shouldn't and can and can't burn. Okay, if we're in a good stage like we are right now, there's no restrictions. When we move to a watch stage, we expect that the wind, dispersions have become poor. We might be looking at an inversion setting up because of cold, or warm front coming in over top of the cold air. So we'll start moving. We'll start maybe call a watch. Particulate levels are starting to build up, and at that point, we do recommend that people with a wood stove start limiting how much you're burning. Burn hot, burn clean. Don't turn the damper down so it's smoldering. And then if we have to move to a pour where we're exceeding that, getting close to that 35 micrograms per meter cube level, or we might push that, we'll call a pour. And at that point, basically no wood burning within the pollution control district. Now, there's a lot of exceptions to that. One of them is if you have an EPA certified stove, which pretty much all wood stoves today are EPA certified that are being sold. Okay, and they have to meet certain requirements as far as the emission rate. And if you're burning with an EPA certified stove, we cannot exceed 20% opacity. So if you walk outside, look at that smokestack and see smoke coming out, you're probably in exceedance of that 20%. So we tell people, okay, we'll send them a letter or we'll call them, say, hey, I'm looking at your wood stove. I can see that you probably are about 50%. You need to burn hot or burn clean. Or some people, maybe that's their only fuel heat source. They can apply for a variance through the board, which we don't get very many of those, and we haven't had any for a long time. But people apply for a variance just because we don't get a lot of poor episodes, at least recently, that people need it. We do have low or exemptions they can apply for, low income exemption, people who are on LEAP, maybe Social Security, disability, things like that, you can apply. Which we still say, okay, this may be your only heat source, but you still need to be responsible. Burn, don't be burning wet wood and burn hot and burn clean. So 3 stages. And if we get into a pour, that's when we start taking enforcement actions if need be, or we'll send out violation letters or whatever it may be. But this winter in 25, 26, very good year. Started out very good. We had 31 good days, no watch, no pour. And it pretty much went that way until December. We had one day, basically it was a half day, we called a watch. And that, I think, lasted 4 or 5 hours and it got good. And then another one in February. So no pours this year, which makes it happy. And here you can see 25, 26 compared back through 2015, 16. No pours, then you show up there on a number of days. And some of these days are a little different because of when we had the board meeting. I think last year we were still in our monitoring season, so I missed a couple of days on that, but very, very comparable. You can see our bad year right here. Things are a little different. So, and it does seem to go in cycles. We get a cold winter, a lot of snow, and little wind, we'll see those issues. So I think that's the last one.
That's it.
Yeah. Okay. So again, good year. We've had to do very, very little enforcement action this year. We have sent out several warning letters and things, but a few warning letters regarding open burning and neighbors being bothered by another neighbor's wood smoke. So generally, all it takes is a letter, and people kind of become responsible. But meaning, and we are moving into basically kind of what's called the shoulder season of burning, where a lot of people do open burning when there's snow on the ground. Well, that'll change as it gets hotter, and they start restricting when you can't burn. We do run into issues with the Forest Service, DNRC, burning large swaths of, say, Mount Helena or Mount Ascension. So we're kind of working through that. We've kind of formed some committees with those companies, DNRC, DAPHHS, Forest Service, as far as how do we address prescribed burning? How do we address wildfire smoke? They're catching heat for, they're trying to eliminate a lot of these fuels, but you also have a lot of that smoke drift right down the valley. And actually, a lot of business owners are very upset, or have been upset with that smoke. So, like, how do we let people know, okay, this is going to be happening? How do you protect yourself from it? So the communication between the agencies has improved much over the last couple of years. So, something we have to deal with. And
Yeah, so we always get a permit, and then they would tell you, right?
yes,
What
like
kind
a
of
burning
watch.
Yeah. So a small burn, like say you're burning a bunch of tree limbs and stuff. Yeah, you get a permit through the county. Yeah, they will tell you, okay, this person's good, go ahead and light it up. As we get into, depending on the time of year, for a lot of people it gets confusing, but as we get into summer months, when you deal with more of the heat, dry fuels, the sheriff can shut down, they'll step in and they can shut down when burning takes place. And we'll make recommendations as far as, dispersion and things like that.
Yeah, we always do it early in the spring when
Yeah.
it's gonna rain or it's snow. There's a little bit of snow on the
Yeah.
ground, and then not again until it's safe in the
Right.
late fall or winter.
Right. And we saw a lot of it last week when we got all that snow. People had a window there to burn. So, and so did the Forest Service. You saw some big plumes going up. So,
They shut down the bunch of the burning the early part of this week
yeah.
because
The
of
wind.
the conditions.
High wind.
Yeah, we did have those fires up in Stickney Creek, and so it all. Fortunately, somebody's looking at that. And so, any other questions?
Are all your, when you said you do enforcement actions, are they all complaint driven? Or on a poor day, do you go, holy crap, look at that dark smoke coming out of somebody's chimney and then
Yeah.
stop? Or how does that work?
Both. Primarily, we're complaint driven, but if we do go to a poor episode, then it becomes okay. I mean, you might be driving out and there's a big plume come out of a chimney. At that point, yes, we
Stop.
and anymore. When I first started, we didn't have as many EPA certified stoves, but anymore we're building a database of that home has an EPA certified stove, or they'll give us that information. Okay. But you are in excess of 20% opacity, you need to burn clean. So we get basically a warning. Like, okay.
Educate them.
Yeah.
Education.
Yeah. And in some cases, we just note that, okay, they are burning, they can tell it. And you have to, in fact, this yesterday or 2 days ago, our guys went to smoke school where you learn to read the opacity of smoke emitting from a chimney. So they can look, maybe the sun is making it look worse than it is. So we'll, watch it for a while. And then, if those people verify to us, they do have an EPA certified stove and they're under 20%. Yeah. But a lot of education goes into it. A lot of, sending out flyers and talking to people about the correct way to burn. So,
Well, that's good because my house only has wood burning and a pellet stove, but I did
Sure.
just buy a brand new pellet stove.
Yeah, and pellet stoves are exempt also. Again, same 20% opacity, so.
Well, and I always thought, well, I never see any smoke coming out of the pellet stove,
Mhm.
and I never have to use the wood burner unless it's really cold. And how can I see smoke when it comes out of the wood burner? So now I know.
Yeah.
Burn hotter.
If you ever want us to come out and take a look, we'll tell you, it's like, yep, you're good or bad.
Okay,
Yep.
cool, thanks.
When things move, to a little, easy for them to burn and not have a fire spread, you're probably gonna see a lot of fires.
Mhm.
The Forest Service was telling us in this general area, they've got about several hundred piles that they've collected, expecting to do them during the winter in the snow, and they aren't, of course, they didn't get
Yeah.
a chance to do it, so.
Yeah, so that, yeah, that's something that, it's a challenge. It's a challenge with our regulations and our enforcement is, especially if we're in a pour, we're moving to a pour. And we're asking people or telling people you can't burn or burn clean. Well, they're burning, and a lot of it is they may have started that fire 3 days ago.
Yeah.
Well, it's still going. So, and they've gotten better at looking at what we're doing, which used to be a common gripe of ours is like, you guys realize we're in a pour episode or we're in a watch and you're lighting up Mount Ascension? Please look at what we're doing. So now DEQ, they have a state meteorologist that looks at those as bursting and he's kind of given the yay or nay on when to burn. And they're paying attention to it, which is what we want. So not perfect, but it's getting better.
Yeah, and they're getting better at communicating with us when they plan to burn so that we can communicate to the public that this is a plan, this is a prescribed burn. Here's what if you are have a medical condition that puts you at higher risk, here's all the things you can do. So it allows us to do communication to the public when they let us know that they're doing it.
Yeah.
So
and that we've also been working on our messaging with we send out during the October through March first season, we send out daily emails as far as the air quality status, the health effects category. Are we like at a good watch and healthy for sensitive groups? Which it gets confusing. I won't get into it, but letting people know, like, yeah, I'm okay to go for a walk or whatever. But we're working on a new listserv, like what's called constant contact with our email lists. We can reach more people. And doing some different messaging things with improved technology. I don't know.
Thank you.
Thank you.
Thank you.
okay.
All right. Agenda item number 5, call for board finance committee. So I don't know if Brenda, if you want to kind of introduce this.
I sure can. Yeah. So, Mr. Chair, members of the board, what we do every year is develop a fresh new budget, and we're in the process of doing that now. That budget will come before the Board of Health. You will vote to recommend approval to the Board of County Commission at the April meeting. What we'd like to do is have a couple of members of the board that are really interested in seeing the details of the budget to set with myself and our finance coordinator and go through the budget, and takes about an hour to get through the whole thing in detail. And we do that because at the Board of Health meeting, it'll be a more high level presentation. And so it's important that a segment of the board actually kind of dig into the details. And so we offer up an opportunity for board members that are interested and would like to spend the time with Heather and I early in April to go through those details in preparation for the board meeting. I then rely on those board members to help present and help answer some of the questions at the board meeting in April. So timing wise, it'll be on the Board of Health agenda at the April meeting, and then I then present the budget to County Commission at the end of May. But that happens prior to the May board meeting. So timing wise, board has to approve, recommend for approval at the April meeting. So the purpose of the finance meeting is really to let you get in to the details of the budget, because we just don't have time to do that during the standard board meeting. So we'd like to have a couple, 2, 3 would be great.
Yeah, so one additional meeting about an hour, and then kind of active participation in the board discussion and in Drenda's presentation to the board.
I'll volunteer.
Perfect, thank you. Is anybody else interested?
It's an hour commitment as well.
It's about an hour, and I once I know who the volunteers are, I can schedule accordingly. So make sure that I can adjust based on your availability.
I'll volunteer.
Thanks.
Do we have a third or?
I'll volunteer.
Thank you. All right. Perfect. So we have Sherry, Mike, and Lisa. I was nervous I was going to have to do it, and I didn't. I am not a finance person, so.
I'm not a finance person either, but I'm still interested.
Good, good. Well, thank you 3 for volunteering.
And yeah, thanks for not making me beg. It seems like the last couple of years, I went to Rex and I said, please, because he's used to looking at, monster budgets and doesn't shy away from it at all. So I tend to lean on him a lot. So I'm really grateful for the volunteers. Thanks.
The board, I just have to tell you that the way that you have worked with the commission on the budgeting has been, the last couple of years, been wonderful. And it's, I know it's been tough.
Yeah.
But it's really important, and there's some really important budgeting processes that we go through to try to keep from having to raise taxes and yet get as much done as we can. Doing a great job of trying to pick up some extra money from grants too, which are helpful.
Yeah, it's a good amount, and we'll present that as a part of the presentation in April. But our revenue, we rely heavily on grants to cover the expense of the work that happens in the department. So we'll break down that percentage again this year, like we've done in the past, to understand how much comes from local tax dollars versus grants, federal and state grants, and then some fee for service revenue that we're able to pull in. We'll do that percentage breakdown again. It's very helpful for the board to see how we're funded, where our revenue comes from. So, but thank you.
Yeah, and I appreciate you pointing that out, Commissioner, because I think we have a very good sense of, how Trenda communicates with us, but to know that that also carries over to the commission and that you see that in your role, that's really good to know.
Yeah, and it's one thing to want more things, but we've got to find a way to pay for it. And there's a certain resistance to adding more property taxes for some reason.
I know, right?
Yep.
For some reason, yeah. All right. Well, thank you, 3. And I think Sandy or Drenda will send out we'll kind of facilitate that.
Yep.
Okay.
Get something scheduled that is convenient for all you.
Perfect. Agenda item number 6, complete Board of Health Governance Function Assessment. So our many times deferred or delayed
needs to be
assessment. We will get back into that and we will finish that today. So I think we're nearly through.
Yeah.
Yeah.
We are on page, I don't know what it is in the packet. It's the board function continuous improvement is the function that we're on. Scroll back. Yeah, you went too far. So there's oversight. There's right there.
This problem question.
27.
Right there.
Improvement.
Yeah, continuous improvement. We're right there.
All right. So for each of these points, there's a kind of binary yes, no from in evaluating the board's sort of effectuation of each function, and then examples and comments it looks like. So continuous improvement generally routinely evaluate, monitor, and set measurable outcomes for improving community health status and the public health agency's or governing body's own ability to meet its responsibilities. So first we have assessing the health status of the community and achievement of the public health agency's mission, including setting targets for quality and performance improvement.
I think we saw a phenomenal example of that last week with the disease monitoring.
Mhm. Yeah, with the like epidemiology, yeah.
Mhm.
Yeah. And I think that that's an example of a place or a portion of that work where the department is leading. And so I think for our perspective as the board, sort of recognizing not just the really high quality work that's coming out of the department, but also how that is other community partners are relying on that, and how that is a not just a public health sort of thing in the sense of serving the public generally, but really serving other public health providers even. Yeah. Anything else on that? Next, supporting a culture of quality improvement within the governing body and at the public health agency.
I think both the presentations we get, like the two we had today of individual programs and things, are a good example of that.
Mhm. I think so too.
Yeah, sort of staying abreast of all of the programs and how the public is interacting with the department.
Do the programs go through any audits?
We are an accredited health department. So we have 10 domains of hundreds of standards and measures that we're held accountable to. And then if it's a grant funded service that we provide, I'll use home visiting as an example. We are held to certain standards by the funder, and those services are audited by the funder sometimes. So there's not a consistent way that looks across the department, but yes, it is happening. And my next statement is actually partly in answer to the first one where we talk about performance, quality and performance improvement. Our strategic plan that we've been monitoring for the past 3 years, we look at progress towards those goals and objectives on a regular basis. And if we're not meeting those goals, we often will make recommendations for quality improvement projects. So there's some performance management and some quality improvement examples of what's happening within the department. I would ask that the board talk a little bit about how you all see your own quality improvement efforts happening. Are there examples of the board identifying, we could do that better, and work to improve the way something's happened so that the next time it can happen better? I think about variances as an example of that, where board members have kind of said over the course of the last 3 or so years, boy, it sure would be nice if we had all the information in the packet instead of just the summary. And so we made that change because the board had identified that as an area of improvement. So gives you something to like
So
a
quality
way to think
improvements
about.
more kind of like KPI, goals and
Yeah.
objectives based, as opposed to an audit type.
Well, and I think specifically, for this is sort of our self-reflection as a board, right? Like we're sort of evaluating how we as a board function as a governing body, separate from, to the degree we can, from how the departments function.
Okay.
Yeah, I think that's a good example. And I also think that I think the cadence of our meetings, the cadence of how we discuss issues, there's a lot of opportunity for us to work with Drenda to adapt sort of agendas, adapt, our plans for meetings so that we can kind of deal with things as they come up, which I think we saw kind of last meeting. We had a lot of things we just had to do, and we did that in, this meeting's a little bit. So I think that sort of environment of working really closely with Trenda as the health officer and understanding sort of we have to be flexible in what the needs of the department are and receptive to supporting that. I think that's a kind of generally, I feel like we operate well in that regard.
My only comment is, so we're not really having any terrible outbreaks or, you know what I mean, pandemics. So we'll wait and see when that happens, how we all operate.
Yeah. Exactly. We've it's, at least since I think we've been on the board, it's been pretty smooth sailing, other than, the initial budget kind of issues, but but from a sort of disease management perspective, definitely.
Yeah.
If there are things that
I know, right?
I don't plan to be around the next pandemic. Are there things that the board would like to see to to formalize quality improvement? So from my perspective, it's pretty informal right now. The board has a discussion like, ooh, that's probably something that we could have done better. Let's do that better next time. But is there anything that you'd like to see to formalize that any differently than we are right now?
I mean, I don't have anything. Again, I kind of appreciate the lack of formality and the adaptability that we have.
Yeah. If it's not broken, don't fix it.
Okay.
Yeah.
I mean, it's working for now.
Okay, holding governing body members and the health director / health officer to high performance standards and evaluating their effectiveness. Well, I mean, we certainly do this with the health officer, right? We have to by statute, so I think that's easy. The annual review. As far as the governing body members, I actually don't know that we have had any discussion of sort of our performance as individual board members, or if there's an issue with an individual board member's performance. I don't know that we have any way of addressing that. I don't even know what the authority would be, since there's an appointment process for all of us, or it's sort of an ex officio status. So I'm not sure. We might need to look into that more.
When the legislature changed that whole governing board thing, I think their direction was they wanted policy to be made by elected officials and implementation by the health board. But really it really took a lot of policy out of the hands of the health board.
Well, even for something simple like someone
Right.
just stops coming to meetings.
Right. Yeah.
Like what's the?
We don't have.
Yeah.
Is that?
I don't know.
Does that go to the commission and say like,
Right.
appointed by the commission? So.
Right. I mean, assumedly, much of the board is on the body because of their position, right? And that's just how that works. But as far as appointed members, I don't know. I think we should probably look into that.
There's a statement of commitment that each new board member reads and signs. It's not re-evaluated unless if you'd like to do that annually along with your conflict of interest, we can include it. But in the past, I haven't had this problem in a long time, but in the past there were board members that just weren't showing up. And we used that kind of statement of commitment. And I asked the chair to have a conversation with that board member and see if they are still interested in participating on the board, or if we needed to replace them, but we really needed them to show up. And that's kind of how we handled that. But that's been years ago now. And but it was that commitment statement that new board members sign that's what we used as a way to set the expectation and then hold board members to that expectation. So.
But to provide education on what our roles and responsibilities are according to the law.
Yeah.
And was that effective?
Yes.
Yeah. Okay. So.
Yeah. And we give board members the options. If this is not a good time for you, or if it's not a good fit for you, this is a volunteer board. So we just resign and we'll put somebody else on that's ready to serve.
Okay.
So.
So maybe we do have a process for that. We just, we just haven't.
No,
We don't have to use it
Yeah,
often, thank goodness.
okay, cool.
and it can be formulated if something really comes up.
Yeah.
Then we'll know a direction that we have to go.
Yeah. And I think in addition to that, the sort of recent discussion and our addressing the media policy, the advocacy policy, you know, that's been top of mind as far as being mindful about how we are you know, how we're taking into account that board members might want to do things outside of the board, but also might be expected to, you know, there might be some issues, right, that we need to sort of get ahead of as far as people want to advocate for things outside of their role on the board. And I think we've done a good job of keeping that top of mind. And I think so like we have a good system of, at least with Drenda, we have a good system of developing policies that are responsive to the needs of the board, I think.
Yeah.
And as new things come up, we know how to address that.
And to clarify, we do re-sign a conflict of interest every year?
Conflict of interest is every year. That statement of commitment, though, is just upon new board members entering the board. So if you'd like to do that annually, we can certainly build that in.
I do it at the same time because it's just a little reminder.
Yeah.
I don't remember when I first came in. I'm so nervous.
Yeah. Well, and
what I signed.
That orientation is robust. So you have a lot coming at you all at once, and a lot of information that you're thinking about.
Yeah.
So an annual review, I think, is
I think that's a good idea.
I really enjoyed talking about the orientation, learning about what they do, that little elevator speech everyone gave, that was good.
We didn't have that, I don't think.
You're not Dr. Nast and Mike.
I know.
We're fancy.
I try to improve orientation every time I do it. So
No, I don't know that it would have made it much of a difference. Like, I think there's so much, right? Examining structure, compensation, and core functions and roles of the governing body and the public health agency on a regular basis. Well, we don't really have compensation. Structure we don't set, and core functions are kind of set by statute. I mean, core functions, right, are set by law. Anything beyond that, I think, well, I don't know. Any thoughts beyond that? I mean,
That's sort of what we're doing now.
Yeah.
I mean, that,
And our orientation
Yeah.
covered that as well.
Yeah.
And the biggest thing obviously recently was the strategic planning, as far as, you know, effectuating our function of sort of setting the priorities of the department, which we're required to do.
yeah, and the other pieces are they happen during budget.
That's really when a lot of it gets.
Yeah, and it's
In order.
presented so that you understand it, but like you mentioned, there's not a lot of power you have over it. So last year, for example, we restructured. And so as a part of your budget presentation, I showed you how we restructured our staffing for budget implications as well as just organizational operations and compensation. That all gets outlined for you in the budget during the budget, but those are decisions made at the county level. So there are things that you are privy to and that you get presented and understand, but like the decision-making body is not the Board of Health.
Yeah, at best, we're making a recommendation.
Yeah.
And cool. Providing orientation and ongoing professional development for governing body members. Well, I mean, we just talked about orientation, yeah. And Drenda kind of improving that with every cycle of new appointments.
Yeah, and you sent me a lot of modules that I could take, how to be a better board member, which were very good.
Yeah, I think that, and I think every meeting we have usually we have some concerted effort, whether it's a presentation or something else, on sort of education and kind of developing our understanding from like a a systems perspective of how public health generally is expected to work and how the department strives to implement that. I think we get a lot of exposure to that, and then how the department is doing compared to those standards. I know Drenda has been very mindful, especially in the last like year, I think, about like arranging our agenda so that we know like, oh, we're meeting that requirement most of the time.
And now Confluent has included a board tract. So for the second year in a row, Board of Health members have access to board-specific professional development at our public health annual training. So you'll have access to professional development through our state organization, which is great.
Yeah.
I've been begging them to do that for a while, so that professional development for board is consistent across the state, and it doesn't fall on me to figure it out every month.
Yeah. All right, oversight. Assume ultimate responsibility for public health performance in the community by providing necessary leadership and guidance in order to support the public health agency in achieving measurable outcomes. First, assuming individual responsibility as members of the governing body for actively participating in governing entity activities to fulfill the core functions. I think that's mostly showing up to meetings and showing up, knowing what we're talking about and being ready to take action on things that we need to. And I would say the again, majority of the board is doing that really well.
Yeah, my only comment would be there's things that come up on like Facebook that the Board of Health is putting out, doing like they did one on smoking, right? And then there's another one that's on there right now. I can't even remember what it is. That, I've never showed up to one of them, but you know what I'm saying? Yeah. So we could probably all be a little more active in that department.
I agree. And it's funny. So I don't see that as I don't know. I don't know. I was thinking, I don't know if I see that as a core function of board members.
So what it would do is it would expose you to what people are saying out there.
Right.
About what. So they're going to the trouble of putting this on for the public to show up. So that's where you get the feedback.
Yeah.
From the public is things like that.
Yeah. And I mean, I thought about that too. And that was, I think we had maybe some minor discussion about this previously, as far as when the health department specifically is sponsoring a public program or a public event, making sure that there's representation from the board there, both to kind of support the department and also, as you mentioned, to get a sense of where the community is at least the involved members of the community are at on a particular issue. And I don't know that we've had occasion recently to, the last thing I can think of was the film series. I don't know if we've had occasion since then to.
There's one on Facebook right now. I can look it up.
Yeah, we often put things out there on behalf of other partnering agencies in the community.
Okay.
I mean, like the Birth Expo is coming up, which is a lot of the home visiting programs, WIC, and like the lead program and some things. I'll be there. So.
There'll be the Community Health Improvement Plan annual presentation in June that you'll all get an invitation to that. I highly encourage you to attend and hear all of the great things that have happened in this past year on the Community Health Improvement Plan, those types of things. But I tend to interpret this in the same way you were, Shannon, and the core functions like strategic planning, evaluation of the health officer, things like the core functions that we've been talking about, each board function, each of the 6, are you doing them? Are you actually engaging in them? It is how I am reading that. So
yeah, like very limited to like what are, I think it's a admirable and good thing for us to do things like that. But as far as a core I don't know. Is it
not necessarily a core function?
Yeah. But I do think that's important. Like, and that's something I think we've talked a lot about, and I talked a lot about when I became chair, was wanting to be conscientious of, okay, there's this event coming up. It's being put on by the health department or sponsored, or, whatever, promoted by the health department. They're involved in. So we need to have board representation there. How are we going to coordinate that? Or we need to make sure somebody's there. And I mean, that's still a priority for me. That's not come up recently, I don't think. So, but I appreciate you bringing that up because, yeah, I wasn't thinking about it as a core function, but I think also there's a degree of if that's something that we need to do as part of our job to understand the community and to understand why we're here to make decisions on behalf of the public, then maybe that is a core function. So, yeah.
Yeah. For me, I guess it cements in my mind that you're partnering with these different agencies and it's all part of public health in some way.
Yeah.
That it just brings awareness to you that that's happening. I guess what we've never heard is how well attended they are. What kind of an impact do you think that they have? Is it changing anything? You know, that kind of thing. I guess if you don't show up, you wouldn't know.
Any more discussion on that? Evaluating professional competencies and job descriptions of the health director / health officer to ensure that mandates are being met and quality services are being provided for fair compensation. A lot of the responsibilities of the health officer are set by statute. I'm only like that part of that question is like your job is set in law as health officer, not necessarily as director of the department. And you're both, right? So I think as far as the compensation aspect of this, I think, you know, we don't have control over that. That's the commission decision. So I don't know that there's been an occasion for us to sort of advocate or a need for us to advocate a position on that before the commission. I think that's what our role would be. Although I don't know how we would know that.
And you can always talk with HR at the county if you have questions about it.
Yeah. Okay.
They really set most everybody's situation. They're constantly reevaluating every position just to make sure that we're somewhere in the ballpark of where we're supposed to be.
Okay.
For those positions.
Meaning how we compare to like other states.
Other communities in Montana or in the Intermountain region.
Yeah.
For instance, we're looking at about figuring this year 2.7% cost of living is kind of what we're doing as we're starting the budgeting process.
Yeah. Okay. That's really helpful actually, because, you know, I wouldn't necessarily expect Brenda to be like, give me
I need your
raise.
money.
Yeah, exactly. Like I want
more money.
I wouldn't want to rely just on that, right? And so if we could take a more proactive approach just to make sure because it is our job to supervise the health officer, and then it's, you know, her job to supervise the rest of the department, right? So we're really concerned with her position. And so I think being a little bit more proactive with HR or something like that, just to make sure we're not neglecting that, because I don't know otherwise, like, I don't know that we've really, it's probably in the budget, and I think
and it will be in the budget, and that we could probably talk about it during the budget.
Yeah.
There's an update to the salary matrix of the county every year that can be easily shared.
Yeah.
And then when there's the reevaluation that happens, it normally only happens for a small percentage of all of the positions in the county. They'll reevaluate, as Commissioner Rolfe just described, where they'll look at similar positions and other similar sized counties across the state and in the region. And so when this position comes up for reevaluation, like I can share that all with the board. I feel like it's partly my responsibility that if I'm concerned, I would bring that to the board too. So, but the county does a really good job of making sure that Lewis and Clark is not the highest or the lowest paid in the state of Montana. And I feel like our positions are paid well across to all of our positions. And that's probably why this has never come up in conversation, is because the county does a good job of taking care of employees
And I think can we make a note that perhaps we should just look into that a little bit more? Not, I mean, it seems like it's working, right? But I wouldn't have known that without this discussion. And I think we should at least know it's working, right? And have some awareness that's not just you relying on Drenda to be like, I'm gonna have to leave if if we don't fix this, right? Just so we have some awareness of that, because right now I don't have any idea, and I think we do have a responsibility
To know that.
to at least monitor that.
Yeah. I think it's been a lot. My position may actually come up soon because it's been a while since it's been reevaluated.
Okay.
So, and the county's been doing it every year. It used to be every other year, but because of the extreme changes in economic, all the economic challenges,
Yeah.
they've been doing annual reevaluations instead of every other year. So when I see that come up and my position is in there, I'll make sure to share that evaluation.
Yeah, that would be great, because I think it is one of the few things in statute that like we're responsible for, as far as not setting this up, obviously, but just providing oversight to you.
Yeah. And then my job description is in your manual, your orientation manual, so you have access to that at all times.
Okay.
That is available on the website under the Board of Health in your board manual. So if you ever wonder, like, what is she supposed to be doing? My job description is in there for you.
All right, hiring and regularly evaluating the performance. Oh wait, no, I'm sorry, I skipped one. Maintaining a good relationship with the health director / health officer in a culture of mutual trust to ensure that public health rules are administered or enforced appropriately. I think that we just saw a good example of that with like the smoke presentation, right? Like that's an enforcement, like that has an enforcement component, right? And having direct conversations with the program, like Drenda facilitating that, and sort of anticipating, what would be a good topic for us to be apprised of, I think has been really, that's sort of self actualizing at this point, I think.
Agree.
Well, and I think the variances are a good example of, I don't even know if you all know, I usually will get an email from Drenda saying, hey, we have this possible variance coming up. We've evaluated it and we think it's something that the health officer can handle. Or this is, one that maybe needs to go in front of the whole board. So I think the communication is great, and it's a function of what the rules are saying about septic systems in the county. So like variances is a good example.
And I think I'll say too, I appreciate you bringing that up, because I think one of the things that's really important to me that I think we do a good job of, but I'm still very mindful of, is that we recognize the expertise and experience of Drenda as well as the rest of the health department, as like really experts in what they do. And I appreciate that. I think everyone on the board feels the same way, like that we are eager to learn from the experts in what they're doing, and what that looks like. And I appreciate their willingness to do that, but I also appreciate the board's sort of recognition of the amount of knowledge and experience we have within the department. I think that's really important, both specifically for Drenda as the health officer, but also for the rest of the department staff.
And I try to be responsive. So if the board has questions, or there's information that you all want, I try to be responsive and make sure that comes before the board, or those questions get answered. So hopefully that's all helpful as well.
Right. Hiring and regularly evaluating the performance of the health director.
We just did that.
Yeah.
Yeah, we just evaluated.
Yeah, we do it annually.
It's time to do it again.
Yeah, I mean, it seems like it was just yesterday.
I know. Yeah, we do that annually, right? And as far as hiring, luckily, I haven't had to deal with that.
Yeah, exactly.
In a while. I've never had to deal with that, at least. I don't know. Have you?
No.
Yeah.
Mm.
Trenda,
Yeah, no, this will be year 8.
Wow.
So,
Mhm.
Oh, man. Okay, last one, acting as a go-between for the public health agency and elected officials when appropriate. I this is funny because Dren and I just kind of talked about this recently, and I don't know. I don't know that we have a lot of occasion for this. Obviously, there are elected officials at a lot of different levels, right? Federally, at the county, at the city, at the state, and we have sort of different approaches to those relationships, for obvious reasons. And I think, we've seen sort of the need for advocacy at the federal level recently, and we've taken steps for that. I think we've also, Doreen and I were specifically talking about sort of like the local county and city government, and I I think Drenda's very good at building relationships and with the county commissioners as well as with other local leaders and elected officials. And I we just had this discussion about sort of what the board can do, if anything, to support that. And um I don't think there is anything right now, but I do think that it's important for us to um be ready if something comes up where we need to advocate for the department and for the well, really for the department in when the commission has to deal with not just the health department but the entire county, and we just get to care about the health department, right? Like that's our job on this board. So being able to perform that role of kind of taking the interests of the health department really directly before the county commission or the city or whatever really is relevant, I think is something that, even though it doesn't come up often, we should be prepared to do if we need to.
and there was an example of that when our budget was really, we were struggling, and we were sitting with county commission, we were sitting with county finance, and Bree McLaren, as the board chair at the time, was attending those meetings. And so she and I would sit with the county commission and the county finance office, and we'd hash it out. Because from the county commission's perspective, there's only so much money.
Yeah.
So we got to figure it out. And then Bree was able to say, but we are required by law to do things. So we were able to have both perspectives at the table and then have a solution that met both expectations, board expectations, that we have a strategic plan that has been set and that we have by law work that needs to be done. And then also meeting the expectations of the commission that our budget is balanced. So, but that was an opportunity for the board to be at that table in those conversations.
I have a question about that. So when I came on, you had just restructured, job positions, plus you moved.
Yeah.
Was that all part of that?
It was,
To get the funds
Yeah.
that you needed to do to operate the health department?
Yeah. We moved our environmental health staff and water quality staff from across town. They were in the city county building into this building. We all got shoved in together, but it saved us $46,000 by doing that.
Yeah.
So
Yeah.
we
Okay.
have bunk bed desks.
One of the kind of complex things that we have more departments that are shared by the city than a lot of places do. And when we share responsibilities, like our RT, we have a joint IT department, and the people that handled the emergency phone calling is handled jointly, and each one of those ones that are handled jointly are either assigned to the city or to the county for the primary responsibility for the budgeting.
Mm-hmm.
And in this case, we've got the health department is underneath the county.
Mm-hmm. Even though it's a city county health department.
Yeah.
We fall under the county for
That is interesting.
That
Yeah.
is, yeah.
There's not a lot
Never wondered
of
about that.
it's, I find it kind of rare, rare bird as I talk to other places. And, but we found a lot of financial efficiency in being able to do that as long as we can work together, work together.
Mhm.
With the city county building and the 406 building where the law enforcement is housed, administrative functions. That's a joint project. Maintaining those buildings and operating the buildings is a joint function. That's underneath the direction of the city. And staffed by the city.
Which is why it's so important to have county commission, city commission, and East Helena on the Board of Health for that very reason. Because even though we structurally fall within the county family administratively, the interlocal agreement says that it's a city county East Helena function, and it's a joint endeavor.
I didn't realize that there was, more government functions beyond just that were shared like that. That's really,
Yeah,
in the case, for instance, of the IT department, we think we probably almost cut in half the cost of operating two separate IT departments. As long as the city and the county can work together, it works. It really works well.
Yeah.
There's a steering committee and a board for IT though as well. So
yeah. Wow. So interesting. So sorry, I lost my place here. Any other thoughts on that?
That was very informative.
Yeah. Thank you, Commissioner. Well, that's the end.
Yeah. And if I were to scroll back through the notes that I took as you all have discussions over the last several months, it seemed as though the 6 functions of the Board of Health, so those 6 functions include policy development, resource stewardship, legal authority, partner engagement, continuous improvement, and oversight, that overwhelmingly you answered yes to the elements of those functions. There were a handful of comments that were noted of areas for potential improvement. And so, Shannon, when you and I meet at our next one-on-one conversation, we should look at those and see if we could build in an action plan of how to address some of the things that the board brought up along the way, because and I can't do it now because it took us several months to get through the whole assessment. So I have to remind myself what those are. But I think at the next board meeting, we can summarize and present an action plan.
Yeah. And I think, if my recollection is, actually my recollection is terrible, but I'm assuming it's not for the sake of the statement. I think those things, they were like improvements, like they were sort of like, we should be doing this better, although it is getting done, or it's, for the most part. And so I think I just continue to be proud to serve on this board and to serve with all of you as board members, because I think this is a very well run board and a great department to get to work with. So I'm excited to kind of refresh my recollection on those and talk with you all about them once Brenda and I have a chance to process those.
Yeah, I just scrolled back up through and there's a handful of comments that were made along the way of, hey, I think let's try this next time, or maybe that's a training item, or so I think that we could get a nice action plan put together for this year. Or this half of year.
Going fast.
It is, yeah. It's halfway over.
Do we have anybody whose term is up in the summer? Do you know?
Not this year.
Okay.
Yeah, next year, Lisa, her 6 years will be up next year.
Okay, so but nobody that we know of this year, assuming
nobody this year.
Okay.
Do I have that right?
Correct.
That's great. Okay, great. Well, I think we have one more agenda item.
We do.
7, yeah, resource stewardship. Yeah.
So speaking of board training, those of you that have been around for a little while know that every April I try to put resource stewardship on the agenda as a training item, because of the fact that this is budget year, or that it's the budget time of year. And so those of you that have been around, Lisa also knows that I use the same training material every year. So I tried to mix it up. I found something different. I do have to apologize though, because it's very academic. And he's really not very interesting to listen to. But after I listen to it, I'm like, okay, so it's not interesting, but the content is good. It does a really nice job of going through federal, state, and local funding of public health. And it does it in a little different way than the previous training materials did. So we're going to give this a whirl, and you can throw rotten tomatoes at me at the end if you think that this was terrible. It's about 20 minutes long, so we'll go ahead and just watch it. We need to make sure that when you share, did you share audio as well? So you might need to start that over. So stop share. Oh, it's right there on the right hand side. It says share sound.
Share sound.
On the right hand side, share options down. Yep, right there.
Share sound.
Yep,
Okay.
so that those online
Okay.
can hear.
We lost online.
Oh, Kelly's not on anymore?
No.
Oh, well, okay. Well, if there's anybody, no public either is on?
Nope.
Oh, okay.
Public Health, Part 11, Public Health Funding. There are no disclosures for this presentation.
Here, let me see if it's on here. Nope. Oh.
Objectives include review the role of the National Health Expenditures accounts in monitoring public health funding, review federal public health funding,
His voice is so.
review federal public health funding plans, review pandemic impact funding, review the public health
The volume.
and health
It could maybe go up a little bit.
BHHS block
There you go.
grant,
Good.
review state public health funding, review local public health funding. Funding for the public health system primarily comes from taxes and fees collected by the government at the federal, state, and local levels. Accurately defining public health services funding from the funding of services from other healthcare disciplines is challenging.
Hey, what was the name of that learning app again?
Oh, IXL.
And it's really helping your kids?
Oh, yeah.
The National Health
There's 3
Expenditure
of
Accounts,
that we have to.
NHEA, administered under the Centers for Medicare and Medicaid, CMS, provides the most authoritative estimate of public health funding and spending. The NHEA categories include expenditures for health.
And it's only as current as 2020. So when it's over, we're going to talk about like more current.
The net cost of health insurance, and investment related to healthcare. NHEA public health activities categories include providing government health care to individual citizens, epidemiological surveillance, immunization vaccination services, disease prevention programs, and the operation of public health laboratories. Activities not included as NHEA public health activities include health research, government purchases of medical structures and equipment, emergency planning, and government spending for public works environmental functions, including air and water pollution abatement, sanitation and sewage treatment, and water supplies. Many public health practitioners would argue that these are also major public health services and activities and should be considered as public health funding and spending. Despite the limitations of these NHEA public health activities categories, the NHEA provides reasonable estimates of aggregate and categorical healthcare expenditures in the United States from 1960, providing a benchmark for trends and comparisons. Most federal public health activities and funding are associated with the Department of Health and Human Services, DHHS, especially the Food and Drug Administration, FDA, and the Centers for Disease Control and Prevention, CDC. Since the 9/11 attacks, substantial additional sources of public health funding comes from the Public Health and Social Services Emergency Fund applied through the DHHS Departmental Management Budget and the Department of Homeland Security. In response to the COVID-19 pandemic, the Public Health and Social Services Emergency Fund and the CDC budgets were significantly increased. Sources to estimate government public health activity and funding include the Executive Office of the President budget for federal agencies and the U.S. Census Bureau report produced every 5 years and the Bureau's annual survey of state and local government finances. Out of the $4.1 trillion budget in calendar year 2020, 5% or $223.7 billion was allocated to public health activities and services.
I'd never heard that before.
This table
Five-
lists
5% of the federal budget.
NHEA public health activities expenditure trends from 1960 to 2020. Total national health expenditures were $27.1 billion in 1960, increasing over 59 years to 3.8 trillion in 2019 and 4.1 trillion in 2020. Public health expenditures steadily increased from $0.4 billion in 1960 to $105 billion in 2019, and in 2020 more than doubled to reach $223.7 billion. Public health activities expenditures accounted for 1.4% of national health expenditures in 1960 and ranged from 2.5 to 3.2% between 1980 and 2019, jumping to 5.4% in 2020. Per capita expenditures in 1960 were $2 per person, increasing to $320 in 2019 and dramatically increased to $680 in 2020. The dramatic change of funding from 2019 to 2020 was related to the COVID-19 pandemic.
Here's how I'm doing laundry in 2026.
Okay. There's 3 of them.
It's 2026. We're not using this stuff anymore.
This pandemic funding provided support for healthcare providers through CARES Act programs and increases in federal Medicaid funding and reimbursements. The CARES acronym stands for Coronavirus Aid, Relief, and Economic Security Act, a $2.2 trillion economic stimulus bill signed into law on March 27, 2020, in response to the economic fallout of the COVID-19 pandemic in the United States. The Provider Relief Fund was part of the CARES Act and provided payments to eligible providers who diagnose, test, or care for individuals with possible or actual cases of COVID-19 and have healthcare related expenses and lost revenues attributable to COVID-19. The Paycheck Protection Program, PPP, was also established by the CARES Act to provide small businesses with funds to pay up to 8 weeks of payroll costs, including benefits, and pay interest on mortgages, rent, and utilities. This pandemic funding
And of course, we had
also
ARPA
stimulated
that came
growth
after that,
in
which
both
gave
the
even more
healthcare
money.
and public health sectors. The federal public health budget is used in two ways: to fund federal activities and to fund state and local activities. Providing categorical grants is the most common method used by the CDC and other federal agencies to fund state and local public health efforts. Categorical grants are use restricted or must be used to meet a federally defined goal and cannot be used to support broader public health activities. Categorical grants are often criticized due to their rigid requirements and guidelines, with little freedom to adjust to the unique needs of state or local populations. The CDC's Preventive Health and Health Services Block Grant is an exception that allows for considerable flexibility in the use of those dollars. The Preventive Health and Health Services PHHS Block Grant Program allows the 50 states, the District of Columbia, 2 American Indian tribes, 5 U.S. territories, and 3 freely associated states to address their own unique public health needs and challenges with innovation, providing opportunities to address emerging health issues and gaps, to focus on the leading preventable risk factors associated with premature death and disability, to address social determinants associated with health equity and disparities, to support local programs that lead to healthy communities, and establish health data and surveillance systems.
That money goes directly to the state and
BHHS
they decide
block
how it
grant
gets used.
funds have been used to provide clinical services, preventive screenings and services, outbreak control, workforce training, program evaluation, public education, data surveillance, chronic disease programs, injury and violence prevention, infectious disease control, environmental health, community fluoridation, tobacco prevention, and emergency medical response. The flexibility of the PHHS block grant is much appreciated by state and local health departments. State health departments obtain funding from federal, state, and other sources. Of these, the federal government provided approximately 53% of state public health funding between 2015 and 2018. The largest sources of those federal funds for states were from the Department of Agriculture, followed by the CDC, HRSA, and other DHHS programs, providing about 45% of state public health funding. State sources were the second largest source of funding for state health departments, providing about 28% of their budget. About 70% of state funding was from the state's
Like
general
some
fund.
Montana specific information.
As mentioned previously, most federal funding comes to states through categorical grants to be used only for purposes specified by grant guidance and can't be reallocated for other state health needs and priorities. This underlines the importance of state and other sources of funding to provide needed public health services not covered by federal grants. Yet each state government is unique with its own set of public health priorities, organizational structures, and public health services provided. This slide provides a few examples of the variability of state public health funding sources. In 2003, even though both Texas and California have decentralized public health systems, Texas appropriated 45% more state funds toward public health than California, spending $99.30 per person on public health versus $14.70 in California. Illinois' public health funding was primarily from federal and state sources, with over half of that from the state. Tennessee received no state or other funds for public health, with all their funding coming from the federal government. The Department of Agriculture, 39.5%, HRSA, 39%, the CDC, 13.5%, and other DHHS agencies, 8%. New Jersey received 45.8% of their public health funding from other sources, with additional significant funding coming from the federal government, primarily from the CMS Medicaid program, 55%.
Our bookstore is like a portal.
It's neo-Victorian, it's steampunk.
And we wanted our Wix website to be too. I'm Jenna.
And I'm Josh, and we're the
Local health departments obtain funding from a variety of sources, including local funds, 25%, state funds, 21%, federal pass-through via the state health department, 16%, federal direct funding, 11%, private foundations, 1%, other sources, 5%, and clinical services, 14%, including service reimbursements from Medicaid and Medicare, 10%, private insurance, 2%, and patient personal fees, 1%. The source and amount of funding depends on the governance structure of the local health department. Centralized departments, or those run by the state, as a mean received $3 per person from local sources, whereas locally governed departments, or those with a decentralized governance structure, received $21 per person, and those with a shared governance structure, $15 per person. Decentralized and shared departments received more funds from the state and federal government versus centralized departments. The population served by local health departments also influences per capita funding. In general, departments serving fewer than 50,000 people have the highest per capita funding compared to those serving larger populations. Urbanization also impacts funding, with urban departments substantially receiving less funding per capita than rural departments. So there is better per capita funding for small, rural, local public health departments that have a decentralized or shared governance structure in the United States.
You'd have a hard time convincing our small rural health departments of that.
Also
economies of scale there
differentiates
that
levels per capita. Local funding is lowest in the South, $14 per capita, and highest in the Midwest, $21 per capita. State funding is lowest in the Midwest, $3 per capita, and highest in the West, $33 per capita. Federal funding is highest in the West and South, and clinical funding is highest in the South and Midwest. Support for local public health may also come from a variety of community partners, including social and human service agencies, primary care providers, hospitals, businesses, community organizations, schools, churches, volunteer organizations, and citizens themselves, and depends on the local economy, market forces, political views, geography, and existing public health infrastructure. As Ashish Jha, White House COVID-19 response coordinator for the Biden administration, said, "We have a very complicated form of government in America, which is because we have a very complicated country. As a result, the ability to move policy resides at a lot of different levels. If you want to try to move it all in one direction, you have to coordinate and bring people along. That is a challenge for all of us in public health, and is demonstrated by the complexity of public health funding." In summary, accurately defining public health services funding from the funding of services
You guys want the
from
summary?
other healthcare disciplines is challenging. The
Pause.
national
Then
health
if you would bring up the slide. Thoughts?
A lot of data
Mm-hmm.
to try to wrap your mind around.
Yeah.
I wasn't sure when he was first started talking. I wasn't sure if he was when he said public health funding. I was not sure if he was talking about like Medicaid. It seemed obvious that he was including that, but then I would expect it to be more than 5% of the federal budget if we're including basically all of sounded like all of HHS.
Mm-hmm.
Yeah.
Well, no, Medicare and Medicaid are much more than 5%.
Yeah, they are.
Right.
But then he was
what-
talking about Medicaid.
It's what's funding public health from Medicaid and Medicare, which essentially is just reimbursement for clinical services that we provide.
So yeah, I guess so then I'm still confused on what he considers public health funding.
Mm-hmm.
Because I would consider all of Medicaid public health funding.
Sure.
Right.
Yeah. I think he was specifically talking about like a public health department.
Yeah. Okay.
Mm-hmm. Yeah. I think of
how it comes down. Yeah.
I think of public health much broader than that as well. I know that it takes much more than just the public health department. If the public health infrastructure or the public health system is bigger, but he was talking specifically about like what's funding the public health department.
Okay. Yeah.
Yeah.
The local public health department.
Yeah. And state and federal. Yeah. So this is actually material that Shannon, you'll get to see at the don't tell them that I showed you this before the conference in a couple of weeks. But this is one of the sessions that will be part of the Board of Health tract, and it is specifically talking about how health departments are funded. But the reason why I wanted to bring this up is I think it's the third one. This one. This is current data about, and this is just Public Health and Safety Division, which is it doesn't include all of the money that comes to the health department. It does not include maternal child health programs for home visiting and WIC, and it doesn't include anything we get from the Behavioral Health and Disabilities Division. It's just the Public Health and Safety Division, but that's a big chunk of how we're funded from the state. But the reason why I wanted to show you this is the funding with COVID dollars that are still coming into the state that expire this year, and then the funding without it. So the color coding is general fund, so state general fund, state special revenue is the red. The federal COVID funds are that big green chunk of the pie, and then federal funds are the blue. So the general fund is the yellow or the gold orange color. It's 1% of the Public Health and Safety Division funding. Most, of course, 83% is from the federal government that funds that section of state government. Gives you kind of a sense of what we get, right? And I think the last time I reported to you, 47% of our revenue was federal funding. 4% was state funding at our level. And then I think the next one is, no, keep going. Keep going. This is tobacco settlement funds. I don't know if that would be of interest at all to you, how the tobacco settlement funds get broke down. But that's state special revenue, right? So when you think about state dollars, it's broken to state general fund and then special revenue. The tobacco settlement funds make up almost the entire pot of state special revenue that we get.
How much longer do those payments go?
In perpetuity, from what I understand.
Yeah. Oh.
That was a
That must
that was a 10-year project for most insurance payers.
But because the previous presentation didn't go beyond 2020, I thought it would be helpful for you to see kind of what the state's reporting as far as the pieces of the pie and how our state health department is funded. And then that pretty much mirrors then how we're funded at the local level.
And so so it sounds like the funding coming from the state government, regardless of whether it originated from federal funding or state funding, is coming through the Public Health and Safety Division of DPHHS.
Most of it, yeah. There's a different division that oversees the maternal child health programs like WIC and home visiting, and those are federal funds that come through the state to the local.
Okay.
Yeah, and when I report to you what the percentages are, that's all federal funds. It flows through the state, but those are federal funds that fund those programs. So very little, similar to what the presenter was talking about other states and how they were funded. We are a decentralized public health system in Montana. And our state doesn't invest in public health, similar to what you saw in some of those other states. So.
Sorry, you said those COVID funds are going away?
They sure are. 2026 is it. There's no more ARPA funds existing after 2026.
That was new, big beautiful bill.
Yeah.
Right? Yeah.
A lot of it got retracted. So last year there was like millions of dollars that just got pulled back. And we were impacted by that somewhat. There was money that the state, that just got pulled back. Like it was given to us to use and then pulled back. And then the rest of it will all expire this year. The county has a handful of ARPA funds left that will be all spent down by the end of this year, and there will be no more.
Yeah, there's really interesting difference between the CARES funds and the ARPA funds.
Yeah. Well, the CARES fund, the intention behind the CARES funds were really to help public health do the work that we were doing with response to the pandemic, whereas the intention of ARPA was broader. They really wanted to revitalize the economics that were impacted by the pandemic, and it was just an effort to restabilize. And CARES Act was really focused on giving public health as much resources they needed to respond to the pandemic.
Yeah.
It was very public health centric. Mm-hmm. Yeah.
But the CARES fund came out without as much direction.
Right. It was just
sent to the county and said,
yeah,
you know best how to handle it.
Yeah.
The ARPA funds, they had very strict guidelines.
Mm-hmm.
And we had to commit to what we were going to spend it on by the end of 24 and have it actually spent and completed, the work actually done by the end of 26.
Mm-hmm.
But they were very restrictive on what we could use it on.
Yeah. That's, in a emergency situation, it's not uncommon for there just be an infusion of funds to get things going. And then the next infusion had more guidelines to it, more boundaries on it. Hopefully that was helpful. He wasn't all that interesting to listen to. It was very much professor, sounded like it was a classroom professor in some university somewhere.
I'm going to get the link and listen to it tonight. I'm going to bed.
Right. Any questions?
All right, well, that's the agenda. Any public comment, anything within the board's authority? Anyone online? Oh, thank you. With that, we'll be adjourned.
Hey.
Thank you.
Thank you. I'll be emailing Sherry, Mike, and Lisa about a time that would work for you in the first part of April.
Tuesday, Thursday, Fridays are my best day.
Do you have preferences?
I'm retired, so
Okay.
She's busier than we are.
I'm pretty flexible.